observation showed features of axonal sensory motor polyneuropathy. A small number of patients had electrodiagnosis feature of small fiber neuropathy. In the mononeuropathy group, the most common was the median mononeuropathy across the wrist, followed by radial neuropathy, ulnar neuropathy, lateral femoral cutaneous neuropathy, peroneal neuropathy, and sciatic neuropathy. The risk factors for developing neuropathy after bariatric surgery included the rapid weight loss, prolonged GI symptoms, not attending the nutritional clinic after surgery, malnutrition state, having post-operative surgical complications, requiring hospitalization, and having jejunal bypass. In subgroup analysis, most of the risk factors identified were related to the polyneuropathy group, suggesting that the polyneuropathy group is more related to nutritional factors and status than mononeuropathy and radiculoplexus neuropathy, which are not related to nutritional deficiency. The active axonal degeneration and significant inflammation observed in 4 sural nerve biopsies done in patients who had very dominant sensory polyneuropathy. Even though the polyneuropathy group had risk factors related to nutritional status, no specific nutritional deficiency was identified in this study. Vitamin B12 and folate level were not different between the group of patients who developed and who didn't develop the neuropathy after surgery. The study emphasized that the importance of having adequate nutritional support after surgery. The peripheral neuropathy is the most common neurological complication reported after bariatric surgery. The etiology of most cases of polyneuropathy was unclear. Many case reports or series showed that the nutritional and multivitamin supplement may help in improving the symptoms of polyneuropathy in these patients. Thiamine also has been shown to be an important cause of polyneuropathy in patients undergoing gastrectomy. In this mentioned large study, the nutritional and vitamin supplements seem not to help in cases of subacute and chronic polyneuropathy. In many cases, specific nutritional deficiency was not found, and common nutritional deficiencies such as vitamin B12 and folate deficiency were not the cause of polyneuropathy. In some of these cases, significant degree of inflammation was found in a sural nerve biopsy. The cause of this inflammatory response remained unclear. In patients who have diabetes or non-diabetic radiculoplexus neuropathy, inflammatory microvasculitis has been shown to play a important role in pathogenesis. These disorders often are associated with significant weight loss and at the time of the onset. Because significant weight loss seems to be a common factor here, it's raised the question whether rapid significant weight loss and in case of bariatric surgery, malnutrition can induce abnormal immune response somehow and causing this inflammatory neuropathy. This question remains unanswered. Moreover, it's also unclear if the immunotherapy alone will be adequate in treating post-bariatric polyneuropathy patients who have inflammation in the nerve biopsy. Post-operative nutritional management and management of post-operative surgical complications remain very important. The recognition of the copper deficiency that recently has emerged as a cause of myeloneuropathy following gastric surgery is important. Because this condition is potentially manageable, it is very important to recognize its early and prevent further progression. When we are talking about mononeuropathy in bariatric surgery, the most common carpal tunnel syndrome And the reason remains unclear because carpal tunnel syndrome is known to have positive correlation to increased BMI and obesity. Many cases of mononeuropathy, especially peroneal neuropathy, have been reported after weight loss and bariatric surgery. The mechanism likely related to loss of fat pad to protect the nerve from compression. The neuralgia parasitica occurs very soon after bariatric surgery, before weight loss happens, and it's seen more often in obese individuals, and it's also more in obese patients who are undergoing the other types of surgery. It's likely the neuralgia parasitica after bariatric surgery result from the nerve compression from the obesity itself. Most cases resolve spontaneously in a few months after surgery. It's possible that rapid weight loss makes the nerve more susceptible to compression. The most common myopathic complication after post-operative from the bariatric surgery is rhabdomyolysis. The rhabdomyolysis is a clinical and biochemical syndrome characterized by skeletal muscle necrosis and release of intracellular muscle content into the circulation, and many result in symptomatic elevation of muscle enzyme or life-threatening conditions such as renal failure, electrolyte imbalance, or compartmental syndrome. The incidence vary from 1.4 to 26%. Typically, CK will peak and reach maximum level on the first day post-operative. Post-operative CK greater than 1,000 used as criteria to diagnose post-bariatric surgery rhabdomyolysis, and CK level in rhabdomyolysis could be high as 50,000. The risk factors include massive obesity and prolonged operative time. Renal failure requiring hemodialysis develop in about 40% of the patients who have rhabdomyolysis. Preventive measures consisting of aggressive fluid replacement, forced dialysis, and urine alkalinization with the CK above 5,000.
2 minutes.
Okay. And we have to be careful about the management of rhabdomyolysis. If the other local study here in Saudi Arabia, consisting of 451 patients, 15 patients have neurological complication. This is around 3% of the patient. And most common, the peripheral neuropathy, then vitamin B12 deficiency, GBS, chronic encephalopathy, copper deficiency. Another study, a review of 15 patients, also the same, the complication, the most common complication, sensory motor polyneuropathy, and about 14% of the patient, and the others have the other complication like chronic encephalopathy. Here the specific neurological complication associated with vitamin deficiency, bariatric surgery, and each one with the percent. How we can prevent these complications? By pre-operative assessment and post-operative assessment and good supply of vitamins and minerals. Here also each type of surgery and requiring supply. The conclusions: the neurological complications after bariatric surgery are not uncommon. Any part of the neuroaxis may involve in these complications. Most of these neurological complications are the consequence of micronutrient deficiency. Physicians caring of patients who have undergone bariatric surgery should be familiar of constellation of neurological disorder that may occur after surgery. And here the post bariatric surgery neuromuscular complication should be taken in consideration pre and post. Thank you.
Dr. Muhammad, thank you very much for this comprehensive and the summary of the subject. Thank you very much. Now we will shift to the second speaker, Dr.
Okay, so put on your seat belts and we'll drive fast. Bismillah ar-Rahim. First of all, inherited neuropathies is very common. And a few things just to clarify at the beginning, and that's number one, the neuropathy could be a primary disorder like primary peripheral neuropathies, or could be a secondary, i.e. part of a systemic disorder. Commonly in pediatrics, we see some leukodystrophies, myrosin deficient congenital muscular dystrophy, or MDC1A, the classical one, could be associated with demyelinating neuropathy. The other thing in terms of the phenotypic classification, you could have either sensory neuropathy, sensory autonomic neuropathy, or the common sensory motor neuropathy, or the CMT, or the other side of the spectrum when it is pure motor. The second phenotypic point that's very important in pediatrics is that CMT could be an isolated disorder, meaning that it has only peripheral neuropathy, or could be a complicated, or what we used to call CMT plus. And this is very important to realize now, that actually the CMT, the pure CMT maybe is this part, but there are many phenotypes that are associated with the neuropathy as part of their spectrum, and sometimes the other symptoms could mask or overshadow the neuropathy, and sometimes you really have to be meticulous to pick the neuropathy as part of the disorder. In addition, some genes are also heterogeneous in terms of their phenotype. Some genes could manifest as a distal motor phenotype or sometimes sensory motor phenotype. And that's why now it's sometimes at the time where we are not sure whether this is to call distal SMA or distal hereditary motor neuropathy. And these I'm sure you will be hearing or seeing in the literature. Rosser tried to design a guide or a paradigm to how to approach patients, particularly those who have additional features, or let's call them CMT plus. In this summary figure, and I think it's important to go to the literature, to the paper itself, because it links to the tables that he put as a differential diagnosis or things to think about. If the CMT plus is manifest with ataxia as a predominant feature, or spasticity, pyramidal signs, or global neurodevelopmental disorder as part of the syndrome, or other features, sometimes just ocular, cranial, endocrine, etc. And then the other type when it is just CMT only. Now, historically, we know that the CMT was classified into the CMT1, the dominant demyelinating, and CMT2, the dominant axonal, and then CMT4, which is the recessive CMT, which could be axonal or demyelinating, and then the third or fourth was the severe early hypomyelinating neuropathy called Dejerin-Sotas, and then the CMTX. Now, I think people are trying to get out of these labels and go into really the genotype, phenotype, in order to define the patients, as I will come later in the coming slides to explain that some genes could manifest either in a demyelinating picture or an axonal picture, and some of them could manifest in a dominant fashion or recessive fashion. And altogether now we really have more than 100 genes that have been identified, and particularly in the past few years, the genetics of CMT has been exponentially expanding. This kind of mixed genotype-phenotype correlation became more of a genotype-phenotype confusion, because not only now you have to really identify the gene, but also identify the phenotype of that gene, and this goes back to the pathophysiology or the impact of that mutation in that gene on the neuronal function. Now, CMT is the most common among neuropathies, 1 in 2,500. We do not really have local data, and the other thing that is also in the literature is that you see most of the CMT literature dominated by adult onset neuropathies rather than the pediatric onset. And one of the things that I think in the adult CMT is that you see more dominant demyelinating, particularly in the literature from North America and Europe. But here we see more of the autosomal recessive than the dominant, and I will show you some data from our local hospital data. Now, this is just to tell you that the genes that are identified as causative for neuropathies or CMT are increasing with time, as you can see in this figure. Really huge increment. Not only that, but also the discovery of multiple variants of unknown significance. We used to check for one gene, PMP22, and then if it's negative, you check the other gene, and then next we developed few panels, and then the next generation panels, and now whole exome. And with that, you tend to see more variants that you really need to study further to see whether these are really causative or just variants. And of course, when it comes to the dominant, it's sometimes really difficult to decide whether this is just a de novo dominant that is manifesting or it's just a variant. These are some of the variants, these are some of the genes that have been discovered since 2012. And this slide, the aim of it, and by the way, Rosser and Mary Riley have many papers that are very helpful to read. And this is just to tell you, based on the phenotype, that this gray is the unknowns. And so a majority is still unknown. Despite all the technology that we have, we still really have many unknowns. Now, why do we have genotype, phenotype differences or lack of sometimes correlation? Is because some genes could, the mutation could affect either the cell body or the axonal or the Schwann cell function or the protein aggregation, mitochondrial function. All of these then will lead to a phenotype that you observe in your patient. So some genes could lead to demyelinating, and in other instances would lead to an axonal phenotype. So the usual approach is, if you have a patient with the classical, typical CMT with distal lower extremity weakness, atrophy, pes cavus, hammer toes, sometimes you might have actually flat feet or pes planus, with the sensory deficit, absent reflexes, and then sometimes sensory ataxia, tippage gait. This is the classical, and you have to go to the classical approach. But then there are the atypical ones that I alluded to at the beginning, when they have more prominent other features like brisk reflexes, pyramidal signs, ataxia, tremor, hearing. Not only that, but you also have to really look at other features in pediatrics, and that's the cognitive learning, hearing, respiratory, vocal cord, etc. I cannot really overemphasize the importance of having a good 3-generation pedigree. This is really very valuable. Not only that, but also don't examine the nervous system, but also examine the other systems, because sometimes you might find clues there as well. These are some of the genes in a pediatric onset CMTs, and here I want to just highlight a few things that in younger onset the phenotype usually is severe, and sometimes the phenotypes in some of them could be dominated by some feature that could be misleading, or could end up the patient into the hands of like a vocal cord paralysis in the hands of the ENT, while the cause is a CMT gene. Now, with the clinical phenotype, I usually start with the lower extremity, peroneal, sural, and then go to the tibial, medial plantar, and then go to the upper extremity. And then the needle electrode examination follows the nerve conduction, with the question whether this is a primary demyelinating or axonal. And then sometimes you have to be really careful. With advanced cases, you may not know whether this is a primary axonal with secondary demyelination or the other way around. Some cases of demyelination, you might find conduction block and temporal dispersion, which then raises the question, is this really a CIDP or CMT, particularly that some of those cases may have elevated CSF protein. And so you end up with the question whether to treat or not to treat. So sometimes history is very crucial in those cases, and I've had 2 instances where I was really not sure, and so I treated, no response, so I thought maybe this is the one. One of them, in fact, I did also nerve biopsy, which suggested that probably it's not an inflammatory neuropathy. This is a textbook approach. I would call it historical approach, and maybe adult neuromuscular would not agree with this, and they will still go with these genes, but in pediatrics, I don't think this is very practical. Why am I saying this? Is because in adult literature, if you look at the cases of the CMT, more than 90% will have a mutation in probably those genes, PMP22 with the demyelination, gap junction B1, MPZ, and MFN2. This is probably not the case in pediatrics. And so what do we do in terms of genetic testing? I think the historical thing is, again, single gene sequencing, multi-gene panel, exome, genome, and then the other testing. And this is just to tell you, from the single gene to the genome sequencing, this creates a lot of dilemma with the variants. The results could be either positive when you find a mutation that is in a known gene and the mutation is known, then that's it, that's the answer. And sometimes you may not find the causative mutation in the tested genes, and many times you'll see variant or variants of uncertain significance, i.e. you have many variants that you need to really study well to see whether these are the causative or not. And if you end up with these variants, you may need to go to the segregation, study the parents and the siblings and see whether this mutation segregates with the disease. And sometimes, not only that, you may need to really check also the literature. There are also good databases, and also consult with your geneticist to help you in this journey. Not all published variants are confirmed. In fact, in this paper, which is very interesting, showed that 27% of mutations cited in the literature were found to be common polymorphisms. So be careful even from the published literature. Another issue is that almost in a study of 15,000 people, probans, they found 83% have variants of uncertain significance. So you are more likely to find a variant than a cause in a given patient. So that's the message of those 2 slides. And if you find a mutation, then you have to see which phenotype does your patient fit. In this GDAP1, you will know, or you should know, or answer this question: is this the recessive phenotype or the dominant phenotype, and which one of them? Now, in my clinic, this is again work in progress, but I wanted to share with you the difficulties we're facing, and these are really very challenging. We had over 70 cases over 15 years, and of course, one of the issues that limits the results of this testing of this cohort is that, number one, genetic testing availability was not there until last few years. The family willingness to pursue further segregation and genetic testing is very important, particularly given that there is no treatment, and therefore why should we do it? And the other thing is the variants, which really need a lot of exercise to answer the question whether this is causative or not. And so I just looked at 59. I tried to remove the duplicates, meaning the other siblings that are affected. And so in those cases, out of the 59, 46 were autosomal recessive, i.e. there is positive family history. 4 presumed recessive because of the pedigree, but no similar family history, and it's unknown gene, so I really cannot answer. And then 4 dominant with positive family history, 2 de novo dominant, I did segregation, the parents are negative, and the child has a mutation that's proven. And then presumed de novo dominant, where no segregation was done. What about their electrodiagnostic phenotype? Most were axonal. One is axonal plus, he has microcephaly and cognitive delay. 6 had more of a distal SMA, which is distal axonal motor, basically. And 1 distal HMN plus, he had dysmorphism. 7 demyelinating neuropathies, and 2 with global delay. This is the total of 59. Now, what did I find? Well, as you can see here, majority were still unknown. And then the commonest is actually heterozygous MFN2. This is what, here 5, and there's another one that is here 1. So 6 out of the identified ones. And then 1 homozygous MFN2, and then 1 of each of those genes, plus also some of them are really, I caution you that maybe these are not the cause, but I don't know. Is this a different phenotype or not? Like for example here, FBXL4. FBXL4 is a mitochondrial disorder which manifests usually with cognitive problems, cardiomyopathy, motor weakness, but the neuropathy is not a well-established primary presentation. So I really don't know whether it is causative, it is a, whatever you call it, novel phenotype or not. And then there are genes that we are still studying. HAD-B is probably a novel presentation of this gene, and again, I'm just putting it because this is what I found in the whole exome, not in the panels. The panels were negative. So the message here is we really have a lot of work to do, and sometimes we may not be able to do given the, the other challenges, the challenges that I told you. And so now my personal approach is if I have a patient with the classical CMT, I go directly to the next generation sequencing panel, which I think will have more focused look at the genes of interest. And I would go for the comprehensive panel, not like the demyelinating or axonal based on the electrodiagnostic panel, simply because, as I told you before, some genes manifest either axonal or demyelinating. And then if the panel is negative, I would go to the whole exome. I favor now more of the trio exome than the single exome. And then, of course, we go through the exercise of confirming gene mutation pathogenicity. Sometimes we really have to go deeper to RNA expression, etc., to answer the question. Some of them we are still struggling with, and so it's not really easy, and you really need to collaborate with other colleagues to learn more about the genetics of CMT. One lesson that I learned through the time is please save DNA after consenting the families, because sometimes many pediatric onset CMTs, they die, and therefore you may lose this opportunity forever. And particularly if they come from far away. So in conclusion, take accurate history, really accurate history, and particularly development, progress, family history, perform comprehensive examination to really, characterize your patient very well, not only from the neuromuscular standpoint, but also from the comprehensive patient standpoint. Look carefully, because sometimes the clues could be hidden somewhere out of the peripheral nervous system. And be careful of sometimes subtle findings. If you see someone with distal weakness and then the lower extremity reflexes are somewhat, you could call them +2, but they are out of proportion to what you'd expect, be careful. Could this be a pyramidal sign or not? So sometimes subtle findings could be very valuable in phenotyping this patients. Also, patients with ataxia, maybe this is part of the neuropathy as well, not only just a primary ataxic disorder. And then it's very important to consider alternative diagnoses, particularly if they are treatable. This is very important.
To my colleague, the chairperson, Dr. Hessa Al-Utaibi. Thank you.
Thank you, Dr. Khan. Good morning, everybody. And now we move to the third presentation in this outstanding conference. And it's my pleasure to introduce my colleague, Dr. Ismail Al-Babilli, who is the adult neurology and clinical neurophysiology consultant. He works in Sulaiman Al-Habib Hospital in Riyadh. And Dr. Babilli will speak about the updates in Guillain-Barré syndrome. Please, Dr. Babilli.
Assalamu alaikum. Good morning, everybody. Speaking about Guillain-Barré syndrome is not an easy issue when you go for updates. It is really a difficult issue since the updates are not that common and the researchers are not that active in this field. Or let me say, not so active in this field. In my talk, I will go through the pathogenesis, the clinical features of GBS and GBS variants. I'll go for diagnostic evaluation, then I'll go for some highlights about the treatment. In every aspect, in every point, I will just try to highlight some basics. So this lecture is not really going to highlight many of the basics, but I hope the residents or the juniors will get good benefit from. And also we'll discuss the most important updates on GBS. Now, in the mechanism of Guillain-Barré syndrome, we know that now GBS is secondary to molecular mimicry. So we have most likely infection proceeding. Then, we have infection proceeding, then we'll have the immune system evoked, then we'll have the autoimmune process. If the autoimmune process is targeted against the Schwann cell, we'll have the acute inflammatory demyelinating neuropathy, and if it is targeted against the axonal membrane, so we'll have the acute axonal, either acute motor axonal neuropathy or acute motor sensory axonal neuropathy syndrome. At the beginning, we should know that 70% or probably more than 70% of patients have reported illness before their presentation. So we started to recognize this on 1976 when the vaccination to influenza H1N1 has been linked to GBS with clear documentation. Though recently, between 1994-2006, it is not anymore, but we'll speak about it in a minute. Now, later on in 1982, there was the first talk about Campylobacter jejuni. And in 1990, a Japanese patient has presented with clear-cut mimicry, and he presented with Campylobacter jejuni infection, then had GBS, and that was clearly documented in 1990. Now, the acute motor axonal neuropathy, acute motor sensory axonal neuropathy, both are axonal, and Campylobacter jejuni happens in 60 to 70%, while acute demyelinating, it is happening, the C. jejuni is happening in 30% only in the cases. And what is interesting that 70% of patients, they report diarrhea only, of those who had documentation of the infection. And we know that the axonal is worse than the demyelinating, and it is more common in Far East Asia as compared to our country or in the West. In 2016, we had a newcomer, which is Zika. The prevalence of Zika with GBS was 1.23%. 1.23% is really quite high. To have infection causing GBS with 1.23 is very high. But the prognosis was not bad. The prognosis of GBS with Zika was 60% of patients were normal after 1 year, 20% were almost normal, running with minimal symptoms. So we have about 80% doing all right after 1 year. And this is almost the same as the other GBS causes, etiologies. Now, when we say we have 70% etiologies, this doesn't mean that we know everything, because lots of viruses, bacteria can cause GBS. Cytomegalovirus, HIV, Epstein-Barr virus, hepatitis A, B, C, E, influenza-like illnesses, varicella zoster virus, herpes simplex. Those are from viruses. Mycoplasma, Haemophilus influenza, E. coli from bacteria, all can be followed by GBS with clear mimicry. We have also the surgical trauma and bone marrow transplantation has been clearly documented and linked. And the vaccination, influenza vaccine, which has been clearly linked to GBS, but the percentage is too low. It is 1 to 2 cases per 1 million vaccinations. So it is really low. But the meningococcal vaccine has linked with GBS more than this, and the other vaccines probably has no linkage to GBS. Now, going to the other parts, the second part of the talk, the clinical features. This is just a quick slide for the juniors. GBS is defined as acute ascending flaccid paralysis with areflexia. Okay, so we have 90% ascending weakness, we have 90% affected reflexes, and will be 100% with evolution of the disease. And we have paresthesia in 80%, we have descending pattern in 10%, we have 15% with oculomotor weakness, which is again descending, and we have the facial involvement, facial oropharyngeal involvement, which can come with descending or ascending pattern in 50%, and we have the dangerous complications, 10 to 30% of respiratory failure and dysautonomia in 70%. 70% of dysautonomia, which is the main killer now in GBS syndrome. The respiratory failure is not anymore the main mortality cause. The dysautonomia is the main mortality cause. And we have the SIAD also causing hyponatremia. In diagnostic criteria, we don't have concentration diagnostic criteria. The first diagnostic criteria has been published by National Institute Neurological Disorder and Stroke, NINDS. This is not stroke criteria, this is NINDS criteria for GBS, published in 1978, and they never updated this criteria till now. In 2011, we have Brighton criteria, and this criteria has been adopted by WHO recently, 2016, and WHO is recommending using this criteria, especially in literatures. Why? Because after the Zika started on 2016, and the difficulty, especially that Zika came in South America in poor countries, so they need to standardize the picture of diagnosis. So they adopted this. And there is also guidelines under development with European Academy of Neurology and the Peripheral Nerve Society, and hopefully will be published very soon. And this includes also the diagnostic criteria and includes the criteria for management. And this, if published, will be very, very helpful. This is the Brighton criteria. Brighton criteria is something aimed for literatures, level A, level 1, level 2, level 3 diagnostic certainty. It is clinical till they reach to cytoalbumino-dissociation and compatible nerve conduction EMG. Here, if it is level 2, should be cytoalbumino-dissociation or compatible nerve conduction EMG, and they omitted the nerve conduction EMG and CSF findings in the certainty of level 3. The variants of GBS are many. This is the first variant to be recognized. What it is used to be called Guillain-Barré, the acute inflammatory demyelinating polyneuropathy, and this is the motor, sensory, motor and sensory motor axonal, which is more common in Far East Asia. Probably the third one is those are the three main categories probably of Guillain-Barré syndrome, and everything else is branching from those three. The third one is Miller-Fisher syndrome, which is a triad for my junior fellows. It is triad of ataxia, hyporeflexia or areflexia with ophthalmoplegia. Now, Bickerstaff encephalitis, it is thought that it is the same as Miller-Fisher, but it is extending up a little to the brain stem, causing some sort of cloudiness of level of consciousness, upper motor neuron, and long tract signs. Now, pharyngeal cervical brachial weakness is probably also another some sort of Miller-Fisher variant. Anti-GQ1B antibody is positive in 90% of cases of Miller-Fisher. It is very important to remember this. Why? Because Miller-Fisher does not always come in a full picture. Can present with ophthalmoplegia alone, like this. Can present with diplegia, with difacial weakness. Can present with some incomplete patterns. So those are recognized variants also. So this is very important to always think about, and this is probably the only marker you should always think about or always send when you have Miller-Fisher. Panautonomia, acute panautonomia is another variant. Paresis is probably incomplete picture of the demyelinating picture, and also the pure sensory is probably the same. Now, this study this is important study published in 2000. Help me, what is this? I can see here, 2018, I think. It is meta-analysis of 34 studies. And it studied the predictors of respiratory failure. And this is very important to know who is at risk of your patients. So the first predictor is hyperacute onset. Patient coming from beginning of his symptoms to the hospital within 7 days. Bulbar weakness and neck weakness can predict this, and severe muscle weakness at the beginning when the patient is presenting to the hospital. Those are very important because the patient who had long ventilation, he will recover in only 18% to be mobilizing, as compared to 76% of recovery for patient who has short mobilization, short ventilation. And this is based on again very recent study. This is the third part of the study of the talk. The diagnostic investigations. Nerve conduction study is the mainstay. can be normal at the beginning within 1 to 3rd day, then delayed F wave will be seen only at the beginning, probably up to 1 week. Then we have a full-blown picture of peripheral neuropathy, either demyelinating or axonal. Lumbar puncture is very important to see the cytoalbumin dissociation. The protein is high, cells are high but little, lymphocytic, not exceeding more than 50, and also to rule out mimickers. This is very important and new modality of investigation, nerve ultrasound. Nerve ultrasound is emerging as important modality, especially in difficult cases like Miller-Fisher, or even in pediatrics, for example. So swollen nerves are seen early, 1 to 3 days. And we can see it also in the coda equina, on the roots of the nerves. And also can differentiate between CIDP and help differentiating between hyperacute or acute CIDP onset, and which is going to be chronic later on, and the GBS, since the CIDP has tendency to affect big sensory nerves, while GBS will have, for example, sural sparing. So if you ultrasound the sural nerve and found it normal, it will be very helpful. MRI also is very helpful in difficult cases. This is coda equina, and we can see it's very clearly enhancing and thickened here on MRI, confirming the diagnosis. Blood works is also helpful nowadays. Low bilirubin is associated with almost every patient with Guillain-Barré syndrome. And also, if it goes down, it indicates that the prognosis is worse. The ESR and CRP are elevated. The monocytes also is indicator of is good indicator of severity of GBS. Cannot be normal, usually is high, and monocytic count, if it is high, it correlates with the severity of the GBS. Albumin, this study has been published in JAMA Neurology last year, and showed that low pre and post albumin is correlating is associated with respiratory failure, and post pre-albumin, low post albumin is associated with poor prognosis. This is another very interesting study, and I encourage every neurophysiologist to stick to this study. Phrenic nerve conduction study in early stage of Guillain-Barré syndrome is very highly predictive of respiratory failure. This study studied 64 patients of Guillain-Barré. 42 of them had phrenic nerve abnormality in nerve conduction study. 22 of them, phrenic nerves were normal. None of those 22 patients who had normal phrenic nerve had respiratory failure, and about 40 plus patients, 40% plus of the affected phrenic nerves went to respiratory support. Now, this is the last part of the talk, GBS treatment. Now, we'll go bit by bit very shortly. When to intubate. Intubation, when you see the patient is really gasping, or the vital capacity is below 20. This is well known and basics. What about non-invasive ventilation? Never ever do it. Never ever try it. It is contraindicated. Though it can help, for example, myasthenia gravis, but it will harm the GBS patient. Now, deep vein thrombosis, patient should be put on high risk protocol. And you should treat pain and sensory symptoms. Don't ignore it. Even if the patient is not complaining, it is common and very common, up to 60 to 80% according to some series. This is very important. You should put the patient on high energy, high protein diet to prevent muscle wasting. Now, this is the killer, dysautonomia. Can reach to cardiac arrest. So you can think about pacemaker if you see clear-cut instability, bradycardia, bradyarrhythmias. Okay. Hypertension should be treated accordingly as you are treating. For example, acute stroke patient, you never allow very high blood pressure. You never allow very low blood pressure. Management of gastrointestinal motility is important. Don't underestimate it. It's 15% up to ileus. Okay, and hyponatremia should be treated accordingly. CAD should be fluid should be restricted, and the other should be increased. Now, the American Academy of Neurology recommendation recommends level A recommendation, both IVIG and plasmapheresis, and it shows it is the same efficacy, while we should start them as early as we can. This study showed that starting plasmapheresis at the first 7 days of the GBS improves significantly the outcome. Mild GBS, we don't know the result. There is a very huge study ongoing now. And we hope it is called International GBS Outcome Study, and we hope it will give us an answer very soon. The Miller-Fisher, again, we treat. Just a very important slide now. There is, I'll skip this, a very important slide now. A new medication which has showed a very, very effective result. It is called eculizumab. It is studied in Japan. It passed the safety first trial, and efficacy was very effective, but the number of patients were still low, to the extent that 74% were mobilizing compared to 15% who received the placebo. The placebo was IVIG. Okay, so the patient had, and I underline Japanese because those patients are always crippled, they have axonal. So eculizumab was safe and tolerable, and probably is coming as very important medicine.
Dr. Ismail, can you conclude, please?
I'm concluding now. Complement 1 antibody is another probably effective, very effective coming medicine under trial. And one other medicine called IDES is in ongoing trial, and probably will see the results very soon. And don't forget that this is the last slide. Don't forget that the patient is going to have 60 to 80% anxiety, depressive symptoms, and the sarcastic thing that GBS predisposed patient to long-term dementia, depression, psychosis. So you should always keep this in your mind. And I hope I conducted something for your benefit. Thank you very much.
Thank you very much, Dr. Ismail, for this informative presentation. And now we move to the fourth presentation in this session. It is an honor to introduce Dr. Mazen Dimashqi, who is a neurologist and clinical neurophysiology, neuromuscular neurologist, and who is certified also in neuromuscular pathology. Dr. Dimashqi, he is the director of neuromuscular division in Kansas Medical Center. He is also the vice chairman for the research at neurology department. He leads a wide variety of neuromuscular research studies locally and internationally. Dr. Dimashqi will speak about the treatment of neuropathic pain and how to avoid narcotics. Please, Dr. Dimashqi.
Okay, I'll let you work on this. Wow. We're having a little bit of technical problem, but good morning, everyone, and thank you again for the organizing committee, particularly Dr. Kapler and Dr. Al-Sharif for inviting me to speak. There'll be a couple more talks this afternoon, and let's see here. I have it on my thumb drive. Let's do that. Yeah. And let me navigate that. So is it a touch screen or no?
It will work. It takes time to load.
Yeah. So let's go to final lectures. Here, this one. And we're going to talk about neuropathic pain right there. Perfect. All right, let's project that. And we're good to go. Okay, great, wonderful. Thanks again for the invite. I only have 18 slides. I usually like to put 40 slides in a 20-minute talk, but I refrain from doing that in the interest of keeping us on time. But one of those 18 slides today is my disclosures, none of which pertain to influence me in any way, shape, or fashion, but they're listed here. Badges of honor as I look at them. So let's go back to the basics. When you're looking at painful neuropathy management, the goal is not zero pain. Because when chronic neuropathic pain, zero pain equals zero function, meaning someone who's laying in bed, not functioning whatsoever. So when I first meet in the clinic with patients who have chronic neuropathic pain, I tell them about what are the targets of treatment. Now, in the US and probably in the kingdom and in the region, the pain score is important. And I think it is important, but it's not the only determinant for treatment success or treatment goal. I think there are three functional domains that are extremely important in managing chronic neuropathic pain. These are people being able to work, whether it's a homemaker, being able to function in the home environment, or at work outside the home, being able to function in your job. That's one. Number two, the ability to do fun stuff. Play with your children, grandchildren, go to malls, play golf, soccer, which is football, actually. That's real football. And then doing things that you really enjoy in life. And number three, being able to fall asleep and maintain sleep without pain interfering with your activities. I've had a patient, for example, who has a pain score of 15. He's on disability. He goes hunting with his dog for 4 or 5 hours. He sleeps okay, and he scores his pain as 15. Do I believe his pain score on a scale of 0 to 10, he says 15, or do I believe his function? I believe his function. So it's important to set the expectation that mild pain is the goal in treatment of chronic neuropathic pain, and that functional ability is the target, not so much so that pain score. Now, once you get past that, then the treatment options in chronic neuropathic pain are antidepressants, anticonvulsants, topical agents, and analgesics, but I put opioid drugs all the way at the bottom of the screen because there are problems with using them, addiction, and other problems that I'll go over down as we go through the presentation. But this is data from painful diabetic neuropathy, primarily studies that are looking at tricyclic antidepressants showing at doses of anywhere from 25 to 75 milligrams per day of amitriptyline, nortriptyline, or disipramine, that there's pain reduction. So these are cheap and effective medications. These are effective independently of their antidepressive effects, but unfortunately, the corresponding drugs, SSRIs, like fluoxetine, paroxetine, and others, are ineffective, with the exception of at the bottom of your screen, there's this one study of escitalopram where a polymorphism in the serotonin 2 receptor has yielded a high retreatment response. But again, this is not a test that's commercially available even in the US, so it's maybe a thought in some of the patients, but don't bank on it. Now, the Other class of drugs that are helpful in chronic neuropathic pain are SNRIs. Venlafaxine, for example, there are studies in painful diabetic neuropathy where venlafaxine at doses of 150 to 225 milligrams per day is effective in reducing pain. It's as useful as an add-on to gabapentin. And this illustrates the concept of combining drugs with different mechanism of action. We'll go over the mechanism of action of gabapentin, but it's not an antidepressant, it's not an SNRI. Combining it with venlafaxine, you have added benefit, added pain reduction, added functional benefits by doing so. And it has minimal side effects when it comes to venlafaxine. Duloxetine is a more balanced SNRI released in now 15 years ago. It's the first US FDA approved drug for painful diabetic neuropathy. It's effective at doses of 60 milligrams per day. I usually push to 90 milligrams per day after a month or two if I need to, but surely I will have more side effects at 90 milligrams per day. And then the most is I go to 120 milligrams per day. And these are studies of fibromyalgia and diabetic neuropathy at the bottom showing that there's pain reduction at those doses that are sustained. But those studies are not long-term studies. They span 3 months for the most part. So that in the clinic, when we treat those patients, we treat them over years. But at least that's what we have from the literature. What about gabapentin? This is the most commonly used drug for chronic neuropathic pain. It's helpful in elderly patients on polypharmacy, multiple drugs, because it doesn't bind to plasma proteins, does not induce hepatic enzymes, and it is excreted primarily unchanged in the urine. And this is the mechanism of action for the residents, fellows in the audience. You'll be asked on your boards. The mechanism of action of gabapentin, it binds to the alpha-2 delta subunit of the presynaptic calcium channel at the level of the dorsal horn of the spinal cord. And even though the name gabapentin has GABA in it, it does minimally increase CNS levels of GABA, but that's not the mechanism of action for that drug. What about the son of gabapentin, pregabalin, that's approved by the US FDA for 3 neuropathic pain states, diabetic painful neuropathy. PHN stands for post-herpetic neuralgia, as well as fibromyalgia in different studies. This is also approved for spinal cord pain. This is one more indication in the last couple of years. Tramadol. How many of you have used tramadol for chronic neuropathic pain? Yes, tramadol is a non-narcotic, but it does have a metabolite that weakly binds the mu-opioid receptor. But also one of the things about tramadol to keep in mind is a weak inhibitor of serotonin norepinephrine reuptake. And the reason why we know about this, or we want to focus on this, is if you combine it with drugs that have a powerful effect on that mechanism, then say, for example, duloxetine or tricyclic antidepressants, then there's a risk of a potentially fatal syndrome called serotonin syndrome in combination therapy. So this is a study that Yad Harati at Baylor College of Medicine years ago did in painful diabetic neuropathy, showing at doses of about 200 milligrams per day, 50 milligrams 4 times a day, roughly, with minimal side effects. Patients with painful diabetic neuropathy had significant pain reduction. Now, when you look up the drug, it's approved for pain, no other specification, not specific to painful diabetic neuropathy, but we use it. We use it because not all neuropathies are diabetic, a large number are, but there are some that are cryptogenic. CMT patients sometimes will have pain, even though classically CMT is a painless disease, so we use it for across different types of neuropathy, chemo-induced neuropathy and others. What about lidocaine 5% patch? Does anybody use lidocaine 5% patch? Yes. And this is from a study that is a PHN study, post-herpetic neuralgia study, where patients who were responding to 5% lidocaine patch were re-randomized to receive either vehicle patch, which is the blue bars, or the yellow bars, which is the active patch, and moderate pain relief, substantial pain relief, and complete pain relief was higher in the actual active patch. And that led to the FDA approval of use of lidocaine 5% patch in PHN. But why am I bringing it up? in painful neuropathy, PHN is a small portion of what we see. We see the diabetic and other types of neuropathy. It's because in someone with localized feet pain, I think this is really an option to try, not for diffuse body pain. And you can use up to 3 patches a day. You cut it up in enough pieces, can be applied in different places. It doesn't typically stick on the bottom of the foot, but on the top of the foot, the side of the foot, the leg, you can apply it and can help you, especially in someone who's elderly, who has localized pain, they're sensitive to medications. It's a great option. Now, let's talk about narcotics. And I talked about the limited evidence here for effectiveness. We don't know that narcotics work for chronic neuropathic pain, and there's tremendous evidence for not only loss of family and community, lifelong disability, dependence, addiction, serious adverse events, as well as overdose morbidity, but also mortality. Did anybody know that narcotics can increase mortality? Yes? So let's talk about what that is about. Here, this is the concept of milligram morphine equivalent. So if you have, for example, if you're using oxycodone here, which is kind of the third from the bottom of the screen, each milligram of oxycodone is equivalent to 1.5 milligram of morphine. And why is that important to know? Well, this is the following reason, is that if you go over 50 milligrams of morphine equivalent per day, the risk of mortality from sudden cardiac death probably is 1.3 to 1.7 compared to the general population. But then if you go above 90 milligrams of morphine equivalent per day, then the risk of sudden death is 2 to 5-fold compared to the general population. So this is an argument that I've used with my patients to make sure I dissuade them from continuing on high-dose narcotics prescribed in pain clinics, but also caution them about going on those types of therapies. Now, I don't mind them being on a low-dose narcotic, something 10, 20 milligram morphine equivalent a day, if I have to. As a matter of fact, 5% of my patients with neuropathy are on low dose. 95% are not taking any narcotics at all. I can manage them with the other drugs. So it's important to keep that in mind. And this is fine print, it's guidance from the CDC about narcotics use and about the rules about that. Some physicians in the US have gone to jail for certain practices, having a narcotics shop prescribing those drugs, like giving someone a prescription for high-dose narcotics or low-dose narcotic and tell them come back in a year. We don't do that. We have them come back in a week or two, see if the drug is effective. First, before you start narcotics, is this the right treatment option? Have you exhausted all the pharmacotherapy that I showed you earlier? So it's not really, and then there's something called a pain contract, where a patient signs a contract whereby if they test positive for on their drug screen for another drug other than the one you prescribed them, not only do you have the right to stop giving them the narcotic, but you can fire them from your practice. So it's really something that's very regulated, and states have different regulations, but I'm sure countries have different regulations around narcotics. Now, it's not hopeless. This is from the American Academy of Neurology guidance on what to use for painful diabetic neuropathy, and there are 2 installments. One of them was back in 2011 and was published and gives different levels of recommendation for the treatment of painful diabetic neuropathy. Of course, not every patient with neuropathic pain is diabetic. However, we transpose those guidances into the other treatment for other types of neuropathy pain. Pregabalin received level A recommendation. Now, in my mind, level A and level B are equivalent, and the only reason why pregabalin got level A is because other studies had a % dropout rate that was more than 20%, which demotes the level of the quality of the evidence. But level A and level B, in my mind, are equivalent, and so amitriptyline was also level B, duloxetine, gabapentin, tramadol, and you see level C, venlafaxine add-on to gabapentin, lidocaine patch, which we just talked about, and the update to that installment is in 2017, whereby oxcarbazepine and botulinum toxin, small dose, 5-10 units injection in different places in the foot, have also been shown to have some effect in painful neuropathy, but there's little evidence to improved quality of life. It's not been well studied. That's the bottom line. So in our clinic, when we see patients, we look at first-line drugs. And the first-line drugs is what you saw on the earlier slide: anticonvulsants, gabapentin, pregabalin, antidepressants, tricyclics, duloxetine, analgesics. Tramadol is in our first-line drug armamentarium. The topical drugs, lidocaine 5% patch. In the US, over the counter, you can get lidocaine 4% gel or 4% cream. That's OTC, stands for over the counter. Second-line drugs, venlafaxine alone or as an add-on to gabapentin. Carbamazepine, that's a drug that's not used as frequently as it should. There's some effectiveness to other anticonvulsants, lamotrigine, Depakote, topiramate, and there's some other drugs listed here. And again, opioids are problematic. You see them at the bottom of the list. So when I tell patients no opioids, we've gone through the pain medication list, they're still having pain, what do I tell them? I tell them, okay, look, there's evidence that from different studies that we did at KU and others have done that there's pain reduction with exercise. So I encourage patients to be more physically active. I tell them, wear neuropathy socks. Some patients swear by a type of sock they wore that controlled their pain. Wear neuropathy shoes. There are certain brands of shoes that are $300, $400. However, they're worthwhile because they avoid treatment with pain medications. Go into a pain psychologist. That patient that I told you that has a pain score of 15, but yet is able to do everything in life, that patient needs a pain psychologist. But cognitive behavioral therapy is something I encourage patients to really pursue. There are some biofeedback books that patients can purchase. But regardless what you tell patients, sometimes they go to the store and get multivitamins and nutritional supplements or practice acupuncture, which are fine by me as long as their vitamin B6 level or amount of replacement does not exceed 50 milligrams per day. Now, things I tell my patients not to do. Interventional regional anesthesia. That should be tested in research studies. Spinal cord stimulation, that should be tested in research studies. Anodyne, in my experience, the crazier the patient, the more likely they'll respond to anodyne. I do not offer it to my patients. However, they bring it up. I don't have a problem with it. I have them try it with a physical therapist. If it works, I have them purchase the unit. It's a near-infrared technology that's supposed to release nitrous oxide and therefore dilate vessels. It doesn't improve neuropathy on the long term, but there's some placebo effect with any pain intervention. So if that's working, why mess with success? And there's been a trial for peripheral nerve decompression in patients with diabetic neuropathy. I don't know if that's prevalent in this region, but bottom line is, the data has not been published, even though the study was done 5-6 years ago. And that tells you a lot about that. If it was a positive study, all of us would have heard about the fact that this is the way to go to help patients. So to conclude, I think it's important to start the right way by discussing expectations with your patients, setting them right that the pain score is part of it, but not all of the story. Function is important, and the 3 domains we discussed and reviewed, that there's multiple pharmacotherapies that are available that have different mechanism of action. You know, many patients with chronic neuropathic pain may have anxiety or depression, and some of those drugs I talked to you about have anxiolytic or antidepressive properties. So you may kill 2 birds with a stone by selecting the right drug, and because they have different mechanism of action. And it's really important to avoid narcotics. An example of that is this cartoon. I'm not sure if you can read it. I have these pills to relieve hay fever, which is hassasiyya, but the side effects are watery eyes, runny nose, and sneezing. So sometimes the drugs we give to patients to treat neuropathic pain are worse than the pain itself, so keep that in mind. And with that, I will stop here. Thank you.
Thank you, Dr. Dimashqi, for this excellent presentation. And now we move to the second lecture, and the rest of the session will be chaired by my colleague, Dr. Amal Khotani.
It's my pleasure now to introduce Dr. Bassam Addas. He's a neurosurgeon and peripheral nerve consultant at King Abdulaziz University Hospital. He'll speak to us about entrapment neuropathy, neurosurgical perspective.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank Dr. Aisha Sharif for this wonderful opportunity and all the organizing committee. I feel odd today. Probably I'm the only neurosurgeon who's talking today, and my topic is entrapment neuropathy. I didn't know exactly what to choose, لكن I have selected few common entrapment neuropathies, and I thought to share with you some thoughts. These will include a little bit of history and physical and some surgical treatment. I'll show a few pictures and videos. Okay? Sorry, it's loading? Yeah. So, طيب. It will take a while. Yeah, so these entrapments will include carpal tunnel, cubital tunnel, thoracic outlet, and in the lower limb, I'll talk about a little bit about the neuralgia, the tarsal tunnel. It's important to remember that there are many entrapments described. However, the common ones you already know, and there are things like pronator teres syndrome. I personally haven't seen one yet. Pyriformis syndrome, it's probably wise to forget about it. Now, you remember it, but it's always at the end of your list. I haven't seen pronator teres, I haven't seen pyriformis, I haven't seen a soleal sling syndrome, I haven't seen a true radial tunnel syndrome. I ran out of, yeah, okay. So we need to remember also that the nerve passes between muscles, under ligaments, in tunnels. So by nature, all our nerves are vulnerable to compression. In entrapment, we really don't know, is it a little bit of demyelination, maybe an ischemia because of a compressed blood flow, or a decreased venous return that causes swelling. It's not exactly clear. Probably it's combination of each one of those. Now, as a general rule, the deficit in entrapment neuropathies are incomplete. And if you see a complete and profound deficit or palsy, think of something else. It's usually not an entrapment. Now, carpal tunnel, cubital tunnel, very common. For every 99 cubital tunnel, you see one ulnar tunnel, which is at the hand level. Extremely rare. Posterior intraosseous syndrome is also very rare. I see 2 cases every 3 years, yani 1.5 case a year. Anterior intraosseous is very rare also, and we talked about the rest. Wartenberg syndrome, or entrapment of the superficial sensory radial nerve at the rest, is extremely also, is very, very rare. And we talked about the lower limb entrapments. Let's start with the carpal tunnel. It's not uncommon for carpal tunnel patients to complain of numbness in the whole hand. You would say, well, it's a median nerve entrapment and it should involve the 3.5 fingers, the classic thing. That's not necessarily true. So patients with carpal tunnel very often will complain of numbness of the whole hand. If you want to go deep into history, you ask them, is the index worse than the pinky? They would tell you, yeah, maybe. Now, usually in the classic form of CTS, the palm is not involved. But you may see patients with palm involvement and they may have CTS. Now, if they exclusively have it in the ulnar side, that's, of course, not the CTS. Now, we all grow up with the Tinel and the Fallon sign. I'm very, sad to tell you, these are useless signs. Tinel has poor sensitivity and specificity, as well as the Fallon sign. What's really interesting, and really you see this in practice, is the flicker sign. has been described by Price Phillips, who's a great neurologist in St. John, Newfoundland, Canada. Basically, the patients will describe flicking his hand when they get the pain, or in our culture, basically rubbing their hands. And that sign has a high sensitivity and high specificity. Now, it's very unusual to see atrophy in CTS. And when they have atrophy, the atrophy exclusively involves the abductor pollicis brevis. And the abductor pollicis brevis is usually at the most radial border of the hand, and you see it here. It's the most radial. Little bit more medial is the flexor pollicis brevis, and underneath is the opponens pollicis. These muscles have a dual supply from the ulnar nerve, and they are rarely atrophied or rarely involved in CTS. And if you see the whole thenar eminence atrophied, that's not CTS. Think of something else, usually a more proximal lesion, lower trunk, medial cord, or when bilateral, think of motor neuron disease or ALS. Some landmarks tells you why we make our incision in the middle, simply to avoid the palmar cutaneous branch of the median nerve, the palmar cutaneous branch of the ulnar nerve, and usually the median nerve is just radial to the palmaris longus tendon. It's not uncommon for those patients to come back to you as a quote-unquote failed CTS decompression, and with pain, with new pain in the palm. Unfortunately, sometimes there are crossing nerves that we cannot avoid from the incision, and these are thought to be communicating branches between the ulnar and the median nerve, and they are basically cut. If you are lucky, you can see them crossing your your surgical field, but sometimes everything is white and you just go across them and you cut them. And the patient will complain of significant pain in the palm post-op, and you would say that this is, the surgeon did not actually remove or inside the flexor retinaculum, or more worse, when the neurologists come to you with a report that the surgeon had injured the nerve, which is very, 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 very unlikely and very, very unusual. And that the pain usually comes from neuroma of these nerves, which usually gets better. Well, let's skip this. Now, it's also important to remember that the outcome of CTS decompression, although it's a straightforward and a simple procedure, is not 100%. Huh? The literature quotes 85 to less than a 90% satisfaction rate. And we know that few patients will not get better, and unfortunately, some will even will get worse. So I take CTS very, very seriously, and because unhappy patients are very, very difficult to manage. The second category is the cubital tunnel. As I've seen, I'm just mentioning a few points that you may find useful. Now, the vast majority of those patients will be happy with just a simple decompression without transposing the nerve. So you just incise the fascia over the ulnar nerve, and that would be adequate for them to relieve their symptoms. We only transpose or move the nerve if you have a previous failed decompression, if you have a cubitus valgus deformity, if you have a preoperative subluxation, which means that when you examine the patient in the clinic, you will feel that the nerve is subluxing under your fingers. And as you will see, if there is an intraoperative subluxation. This is the cubitus valgus. Those patients with a previous history of elbow trauma, years, maybe 10, 15 years ago, and now the area has been deformed, and if you decompress them, the nerve will keep subluxing and hitting that exuberant medial epicondyle, so you better transpose the nerve. And the way intraoperatively what we do after we decompress the ulnar nerve, we flex the arm, and if the nerve moves anterior to the medial epicondyle, as you can see, the dot marking the medial epicondyle. So if the nerve moves above the medial epicondyle, it tells you that it requires a transposition. And eventually, we transpose the nerve, and we keep it there by fashioning a sling. Now, these vessel loops are around the medial antebrachial nerve branches. It's very unwise to cut those nerves. Patients will have a very painful neuroma post-op, and the patient will come to you with a picture even worse than the pre-op, and the reason is because of the very sensitive and very painful neuroma of the branches of the medial antebrachial nerve. Eventually, after the surgery, the nerve has to have a straight, smooth course, and every flexion of the elbow will releases the nerve even further, or relaxes the nerve even further. The next category is the posterior intraosseous entrapment. Very unusual. What is very characteristic of those cases is that they will have an incomplete palsy of the finger extensors. So you may have the index only, you may have the middle or little, usually an incomplete injury or incomplete palsy. And you can see here you have an intact wrist extension but a weak finger extension. It's important to make sure that this is not an incomplete radial nerve palsy. You check the brachioradialis, you check the wrist extensions, and of course the common radiculopathy to differentiate from a C7 radiculopathy, which has a very characteristic dermatomal and sensory pattern. It's also important to remember that the pin is not a purely motor nerve. It supplies distally the wrist joint, and it's usually we cut the distal branch of the pin in patients with resistant wrist pain. Every time you encounter one of those rare entrapments, just get an MRI. So if you see an entrapment every 2 years, it's worth getting an MRI, whether it's the common peroneal, whether it's the posterior intraosseous, whether it's the tarsal tunnel. Just get an MRI, and it's nicely illustrated in this case where we opened this case as a case of idiopathic posterior intraosseous neuropathy. Luckily, we had a preoperative image that showed a tumor. We said, oh, this is nothing. So we went in and we did the decompression, but very quickly we realized it's not an impressive decompression. We went back to the radial nerve, and just to find that the tumor, it was a perineuroma that was resected, and that piece with the nerve was grafted. The classic decompression of the posterior intraosseous involves cutting the arcade of Frost. Arcade of Frost is a thickened fibrous interest to the supinator muscles. It's always there. However, in some patients, it becomes problematic and compresses the nerve. And all what we do is we just basically slice the superior border of the supinator all the way till the nerve branches, as in these pictures. A very interesting and relatively common, neuralgia is quite common. I see a case every maybe 4 to 6 weeks in the clinic, and it can be a nuisance. This slide is clearly showing that the nerve does supply part of the buttocks. So classically, you would say, oh, it's just the lateral aspect of the thigh. Remember that it does supply part of the buttocks. And when it supplies the buttocks, we think of L5 or S1 radiculopathy, and it takes us away from the lateral cutaneous nerve. So putting this in mind, that still qualifies for the neuralgia. The other anatomical picture shows how variable that nerve is, how many branches it has, and it may have 2 major branches or so many small branches, and that explains why sometimes the surgical intervention fails to achieve their goal. Now, it's believed that an obese abdomen will dangle down and will kink the nerve, and that's why the symptoms are produced. But actually, we don't know exactly. Is it a tight belt? Is it a big belly? Sometimes you see it in patients who loses weight, so it's not clear. Now, it's important to remember that only 60% of those nerves will have a classic usual course. So it's not surprising that you examine them, they don't have a Tinel sign. And when I inject them in the clinic, I make sure that I infiltrate the whole area of the anterior superior iliac spine, because just to include the different anatomical variations. Surgery is saved or reserved only for the resistant cases, because it's not a very satisfying outcome for the reason I've mentioned. Here is a patient with so many branches, and you have to go to the inguinal ligament, you cut the inguinal ligament, and this is another patient where you see that the major nerve is there, but there is a small branch, and if you don't go all the way backward or proximally, you will be missing it, and you are running the chance of having a residual symptoms. So if you have a compression, why do you cut the nerve? Why do you just decompress it? Simply because all the studies have shown that cutting the nerve is superior by just neuralizing it. And most of the cases where it was neuralized only, we had to come back again and to cut it. Few words on the tarsal tunnel. It's a very difficult entrapment to treat. So many EMG comes with the diagnosis, but the clinical examination and the clinical scenario does not fit with the tarsal tunnel. We know very well that there are so many causes of heel and foot pain, and we also know that the EMGs can be false positive in many of those cases. So you have to be very careful before you offer the patients decompression, because the results are not as good as the upper limb entrapments. Always uses imaging. Always uses imaging with the tarsal tunnel syndrome, particularly when it is not following an ankle injury or history of previous trauma or ankle surgery. When it is a de novo or primary, don't hesitate of getting an MRI. That's a case as a tarsal tunnel, where basically we have a schwannomatosis with many nerve sheath tumors. And even with cases of synovial cysts. So these are the two pathologies that usually confuses you with the entrapments, tumors and synovial cyst. Rarely we have accessory and anomalous muscles that can be removed to release the nerve. The last category I just want to go over is the thoracic outlet.
Dr.
An
Bassam,
enigma.
we have 1 minute to go.
It's an enigma. I still have, okay. It's an enigma. all the neurologists know neurogenic thoracic outlet, which basically compression of the lower trunk. We also know the vascular thoracic outlet, the arterial and the venous. These are very clear pathologies. However, there was a big category called the disputed form, where the patient is having neck, arm, forearm, hand pain, very nonspecific, very subjective. And unfortunately, this is lumped under neurogenic. Now, when you say the word neurogenic thoracic outlet, it's not the classic Gilead-Sumner syndrome, where you have an atrophy of the hand muscles. Now, neurogenic thoracic outlet is this constellation of neck, arm, and forearm pain, which is very confusing. The classic neurogenic syndrome that we see is the one that is associated with clear compression due to cervical rib or bands, something actually you can feel clinically. You do the images, you see an accessory, clearly an accessory rib on the left side, C7, and we'll just go over this. You will just basically intraoperative, these were videos, but we don't have the time to show. And you basically go in and you resect the accessory rib. And as you can see in this case, the T1 is completely draped over the accessory rib. That's all what I wanted to say. Thank you very much.
Thank you, Dr. Bassam, for this great lecture. I will move now to our next speaker, Dr. Muhammad Al-Miheza, who will speak to us about pediatric EMG.
عشان يشتغل هذا هذا عبر صح دكتور؟ احنا عم ناكل شويه بعد. تفضل دكتور ابدا اتكلم.
Okay, Bismillahirrahmanirrahim. Again, ختامه مسك, I think, I hope. For the sake of time, I may just run through a few slides because I think this symposium is full of EMG and neurophysiology, so I will try to focus on لا طلعت نص. Sorry, it was okay. I will try to focus on some of the cases and the learned lessons, as the title is actually Pediatric EMG Pearls and Pitfalls. So my pearls may not be your pearls, you may be your usual thing, and my pitfalls may be something that you know. So I hope you take it from me as what I learned throughout the years. And sure you know that the EMG consists of routine nerve conduction, needle electrode examination, plus special reflexes and repetitive stimulation, etc. And that in the objectives of EMG is you want to localize the site of the lesion, the pattern or the type of pathophysiology in terms of whether this is a demyelinating or axonal, it's motor, sensory, or combined, whether it's generalized or focal, and try to get an idea about its tempo, whether this is acute, subacute, or chronic, acquired or inherited. And then sometimes you may go further to assess severity, like motor unit number estimation, etc. And the needle examination, I'm not going to go through it. There is a workshop about it, but these, I just wanted to point out that these videos are on YouTube. Very nice videos by John Kimura And I think there is also many resources that will help, make your ears very skilled to understanding and realizing the needle electrode examination, particularly to understand the spontaneous activity, the neurogenic, myopathic changes. And I want to tell you that these are more of adult kind of examples. And so the pediatric sometimes need to fine tune to the pediatric, particularly when it comes to the sounds. Particularly when it comes to the neurogenic and myopathic patterns. Now, what's the difference between adults and pediatric? Now, of course, kids cry. So they added an extra noise to the EMG rather than more than the noise that you see on the screen. And this noise may put pressure on the electromyographer as to go fast, do the minimum harm, and get the best answers. And this is very important point because, and I will come back to it many times, as that you really have to plan your EMG for a pediatric patient ahead of time by understanding the patient history, examination, etc. And so you design it based on what is the best and most likely to give you the answer. So go where the money is, rather than applying the rules. In adults, for example, ALS, you have to examine 3 limbs, whatever. There is a confirm. In pediatrics, this may not be the case. Luckily, we don't see that many ALS, so we don't have to go through that pain that frequently. Now, they do not cooperate, so when it comes to needle electrode examination, they will not, help you. Okay, contract a little bit, see more. They don't do that. They cry, they may contract, or they may even not move that limb, and so you may have to deal with what you see on that, test. They grow, and we know that the nerve conduction velocities, latencies change, particularly in the first year, and more for example, in the first half of the first year. And we know that the conduction velocity usually is about half at birth than the adult velocity. And the other thing about maturation is the lack of good reference normative data for kids. And if you look at the literature, you see, series here and there, and so this is another challenge when it comes to the normative data. And kids are smaller, and therefore the measurement error has more impact into the values you get compared to adults. So, a distance of 3 centimeters is different from 7, 8, 9, 10 centimeters in, for example, upper limb. Now, what are the common disorders we encounter in pediatrics? The commonest referral is maybe a floppy infant, hypotonia. This is historically a common referral, but also we see many of the neuropathies, so that's another important thing. In my practice, I see many brachial plexus injuries of newborn because our orthopedic surgeon insists on getting a nerve conduction, and I took this as an opportunity, which I will explain later on. But I know that the need for doing brachial plexus EMG is sometimes debatable whether you really have to do it or not. Clinical, MRI and the history may be enough to guide the management. Myopathies, of course, and particularly congenital myopathies when they have a normal CK. This is another referral. Anterior horn cell diseases, in particular when you want to get an answer because genetics takes 6 weeks plus sometimes. And then neuromuscular transmission disorder like myasthenia and myasthenic syndromes, and then myotonic disorders. Now, in kids, in general, at birth, as I said here, it's half the adult value in terms of conduction velocities. The adult values are reached by 3 to 5 years. Most studies that are published are orthodromic, but sometimes sural nerve could be difficult to obtain in young infants. And if you look at this data here, they said sural nerve any response because, again, of the wide standard deviation. So that tells you how variable is the normative data for the sural, for example. In the motor studies, distal motor latency tend to follow a U-shaped curve during infancy. That's due to the myelination and lengthening of distance. And the mean median amplitudes increase steadily, but standard deviations peaks in toddlers, and young adult amplitudes are generally higher than standard adult values. So these are very important to keep in mind when interpreting these studies. Now, F latency is also another study that follows a U-shaped curve during childhood due to competing the influence of myelination and lengthening of the extremities with age. And sometimes reaching the mature adult values could lag behind the routine studies. As I said, years ago when my former colleague, Dr. Stixby, was the head of the EMG lab, I used to ask him, do we have normative data for kids? And he would give me the Buchthal references and then the other references. And the age that it goes down is age 14. If you add to it some of the published case series, which are, a couple of patients on the median, ulnar, etc., showing you the range, there is actually nothing local. And I remember Dr. Stixby attempted to do that on few patients in the past, and then he created a graph. Subsequently, we lost it in the lab, so I'm trying to get that graph that he created. But who will agree to volunteer to test his son with this painful, torturing test? So from these patients that Dr. Nizar Hamdi was referring to us, we thought, let's compare to the contralateral normal limb in order to get an idea of how much, and particularly that some studies on the brachial plexus severity assessment showed, for example, the biceps CMAP, if it is dropped more than 50% compared to the normal, that indicates a poor prognosis and probably a need for surgical intervention. So we did review our cases that were evaluated between 2000 and 2018. And out of the 120 patients, we had these age ranges. And I want to go quickly because basically these reflect what I told you about, the distal motor latency increasing and then going down. This is for median, and then on the right side on the ulnar. And then this is the amplitude going up and then going down, U-shape. And one of the challenges, like for example here, ulnar, I'm questioning because here it's more or less the same for the first 7 to 8 months, and then it goes up and then goes down later. Again, if you look at the number of tested nerves, that makes a big question. That's why we are actually moving into creating our database so we can really acquire the data and then refine the curves as we get more data. Now, this is a work in progress. It only includes upper limb. We still need something to do on lower limbs, and we're thinking of an idea to get some normative data. But I think this is something that colleagues even in Saudi Arabia are encouraged to do because we don't have local normative data. Now, these are the requests that in my clinic I've received, and mostly basically highlight the findings that the disease I told you initially. And I will end up by giving you a few case examples and highlight some of the points that are my pearls and pitfalls for pediatric EMG. This is a patient who was actually seen by pediatrics because he was healthy before, 10-year-old, and the father came with a history of progressive weakness to the degree that he lost ambulation over a period of 4 weeks. And so they did CK, it was 1,500 units. So he went to someone who told him, well, this could be Duchenne, because boy, this high CK, this is Duchenne. So they consulted me because at that time I was doing muscle biopsies. So they asked me to do a muscle biopsy. simple thinking by a pediatric neurologist, 10-year-old who was healthy before and now becomes Duchenne, this is unheard of, so it doesn't make sense. So I told him this is not, Duchenne because of the history, because of even the level of CK, so it's not. But the father was fixating on this, and he wanted to answer this by a muscle biopsy. So they ordered EMG, and the EMG was done by, with all due respect, an adult EMGer, but I'll tell you, I'm not blaming him. There were subtle myopathic changes on the EMG conclusion. So they told me, well, listen, this is muscular dystrophy. We need a muscle biopsy. And so they said, they ordered DMD gene. Again, wasted money. I said, well, I'm not going to do a muscle biopsy. Do MRI because it will show you clear findings. So they did a muscle MRI. I went for a leave. I came after 2 weeks. They were just like literally standing by the door saying, listen, even the MRI shows some signal abnormalities. I said, I cannot believe it. So I went to the radiologist, and there were sure some signal abnormalities, but this is because this child was receiving vaccines in the quadriceps. So that led to some of these changes that were found by probably the needle exam, the MRI, everything, but it's not the muscular dystrophy. And sure enough, it turned out to be, probably functional. There were some issues behind that, and then he improved, afterwards. So the message here is, had we believed in some of these interpretations, we would have gone through the wrong interpretation and unnecessary workup. And that's why this is just one lesson from this is, as a neurophysiologist or an EMGer, please try to make your impression readable and understandable to the requesting physician, and also answer his question. They're requesting it because they're suspecting Duchenne. The answer should have been, while there are maybe subtle myopathic changes, this is not a Duchenne muscular dystrophy finding based on the needle electrode examination. The next patient is a floppy infant. I will go through case, so you can stop me at any time. Of course, after finishing some cases. This one is a 2-month-old hypotonic with minimal subgravity movements, no facial grimacing, CK normal, EMG question mark myopathic, short duration, and remember, this is 2-month-old infant. So muscle biopsy was done, and there were non-specific myopathic changes, variation in myofiber size, sometimes nuclei are not are maybe in the center. So it was not really clear. Diagnosis came back Prader-Willi. The lesson here is sometimes, in fact, EMG, I was disappointed because I did the EMG and I said, oh, I made a mistake. So I talked to Matthew Pitt in UK. I was telling him about the accuracy of needle EMG, and he told me, you'll be lucky if you are 50-50 accurate. This is, again, same shared by the colleagues in the US. So Charles Bolton and his colleague, because EMG in infants younger than 6 months for myopathic disorders you should really question it. For neurogenic, maybe you will be more right than wrong, but for myopathic, you have to be really, really careful, and sometimes time is enough to give you a hint. And particularly in Prader-Willi syndrome, sometimes they are so floppy and weak that sometimes you may think, oh, probably they have myopathy, they have congenital myopathy. But give them time, examine them carefully again, and probably this will save you from another test. Next patient. Again, by the way, Prader-Willi syndrome is common. Another floppy. 3-month-old infant who had myopathic-like face, but not that typical, no ptosis, needs nasogastric tube, family history negative. Again, we went through the Prader-Willi myotonic dystrophy testing, all negative. CK was normal, and the question was whether to do muscle biopsy, yes, no. The EMG, interestingly, with the nerve conduction, there were no elicitable CMAPs. Whatever how much you provide, no CMAPs elicitable, yet there were some movement. So it's not like there is axonal motor neuropathy, but you could not elicit CMAPs. The sensory, sural, ulnar synapses were fine, and so it's not really technical. Needle exam, no spontaneous activity. I could not get the baby to move or activate the muscle to evaluate the voluntary motor units. But that's what I have. So, what would you do? 3 hertz, because there was no CMAP, you cannot do 3 hertz. I mean, slow, repetitive, whatever. Well, it turns out this girl had a very rare and recently described mutation in the VAMP1, which is vesicle associated membrane protein 1, which basically causes a congenital myasthenic syndrome similar to a presynaptic like Lambert-Eaton. So in retrospect, well, could you have done fast repetitive stimulation? And this is very painful for an infant. And so when we gave her the mistinone with repeat CMAP, we were able to elicit, so that indicates that there is some response to mistinone with also some added response to albuterol. But the point here is, even after asking about diurnal variation, which was, not there based on initial history, when we insisted later on, the mother started to focus on the baby, and she noticed at the end of the day that she's not moving as active as in the beginning of the day. And initially she was thinking, well, this is a baby, afternoon she is tired. But in retrospect, there was a diurnal variation, but was very subtle and was probably overlooked. So I mentioned this, it's a recessive. Interestingly, VAMP1, by the way, is reported before as a cause of spastic paraplegia in the dominant inheritance. But for the recessive inheritance, it's just being described in 2015.
We have 1 minute to go.
1 minute? Okay, so for congenital myasthenic syndromes in the EMG lab, we know that these are heterogeneous group and variable phenotype. Dr. Zaidi, I think, will speak about congenital myasthenics. But you will be lucky if you see double CMAP in some of the slow channel disorders. You may see decrement, but not that common. And it's, by the way, less common in pediatrics than adults, so that's very important to remember. And single fiber EMG is technically difficult unless you sedate the patients or you develop the skill of stimulated single fiber that Dr. Matthew Pitt does in UK. And of course, I think that's it. The last one, the limb girdle phenotype. I think I will skip it. I will just mention that this example of a patient who was ambulant with proximal weakness, CK normal, positive Gowers, so it's a limb girdle kind of phenotype. EMG, nerve conduction was normal, needle examination showed chronic neurogenic changes, so mostly SMA, and you have to know, SMA causes predominant quadriceps weakness as opposed to the limb girdle, which causes a hip flexor weakness. Predominant, and this sometimes is a clue for a clinician to differentiate between limb girdle muscular dystrophy versus SMA, particularly when you have an elevated CK. Now, this patient had 3 SMN1 copies, so extra SMN1, SMA, so SMN1, yes, and 1 SMN2 copy. So I was really thrilled. Well, this is maybe a new phenotype, so I got to publish it. Unfortunately, I did not find anything to support this. And then of course, he had a muscle biopsy which was neurogenic, but then whole exome showed a de novo mutation in the dynactin gene, which causes a lower limb predominant SMA. So it's a dominant lower limb SMA. And the clue here is the upper limbs were very strong. And so if you examine the patient carefully, you see very prominent, very strong upper limbs, and the symptoms are lower limb. Of course, if there is no things to suggest cord, this would be very good pick by just clinical. So the message here is careful tailoring of your examination after taking good history. And I will just move into the last conclusion because of the time. EMG should be used as an extension to your history examination and ancillary testing, although some exceptions exist. If history examination and ancillary testing does not give you an answer, then EMG will most likely not give you the answer. If in doubt, re-examine the patient. Obviously, in children, EMG is an opportunistic task and not a guideline-driven protocol like ALS, and normative data should be used cautiously, and again, if in doubt, retest. Now, I should acknowledge that these are lessons I learned from Cleveland Clinic from Asa Wilborn, who was a pioneer EMGer, because this is very important not to forget that EMG is an extension to your clinical tools as opposed to the EEG, which is used independently. Thank you.